Hello and welcome to HLA webinars. Thank you for joining us today. My name is Carla Byers-Smolin. I am the National Chapter and Membership Coordinator for HLAA and your host today. Today's presentation is Cochlear Implant Standards of Care and International Consensus. Please know that this webinar is being recorded and will be available at a later time on the HLA website at hearingloss.org. I need to give you some technical tips to get started. Captions are available on the slide presentation on the purple bar below. You do not need to enable the subtitles. We encourage you to open up your chat box and move the box on your screen to avoid overlap of captions and chat messages. Please use chat for comment exchange or for technical issues only. Please click on the Q&A icon to ask any questions. We will be using this feature to facilitate questions after the presentation. Your screen should be in side-by-side mode if you've joined by computer. There should be a shared screen with the presentation on the left and the speakers should be available on the right. You have gallery view or speaker view. You can choose that in the right-hand corner. You can adjust the size of your display by scrolling in between the two screens. There should be a gray bar that you can adjust to your desired size. If you join by mobile device, you may have a different screen. You may have to scroll between views to get to your desired one. I have covered tech tips, and right now I'm going to turn this over to Barbara Kelly, who is Executive Director of HLAA, and she will now introduce the guest panel. Go ahead, Barbara.
Thank you, Carla, and welcome everyone. The world's first international consensus paper on adult cochlear implantation was published in JAMA Otolaryngology recently. This new study focuses on treatment for adults living with severe to profound sensorineural hearing loss and recommends minimum standards of care for diagnosis, referral, treatment, and aftercare. 31 experts on cochlear implants came together to create these standards of care. And in addition, a consumer and professional advisory committee, we call the KPAC, was involved to ensure that the consensus statements included perspectives of people with hearing loss. And I am pleased to say that HLAA took part in this process. I had the honor of serving as the US co-chair along with Dr. Harold Seidler from Germany, who is a CI surgeon and a CI user. You could read more about the process and everything and the consumer role on our website at hearingloss.org. We are very fortunate today to have two guest speakers. Dr. Craig Buckman is the Lindbergh Professor and Head of the Department of Otolaryngology, Head and Neck Surgery at Washington School of Medicine in St. Louis. Professor Buckman was the chair of the Delphi consensus process that created these consensus statements and was the lead author on the international consensus paper. We also have Dr. Renee Gifford. She's an audiologist, and she's one of the 4 steering committee members of the Delphi consensus process. She is professor in the Department of Hearing and Speech Sciences, and she has a joint appointment in the Department of Otolaryngology at Vanderbilt University School of Medicine. She is also the director of the Cochlear Implant Program at Vanderbilt's Bill Wilkerson Center. So thank you both, and I will turn it over to our presenters.
Great. Thank you, Barbara, and thanks to the HLAA for allowing us to be here today and present. I'm going to present about this consensus process, as you heard, but I'm really presenting on behalf of our Delphi consensus group, which was the group of 31 people that Barbara referred to, of which Dr. Gifford, of course, was one of those, and also for the KPAC, and we'll talk a bit about that as well. So let me advance. So these are my disclosures. The important disclosure here is Oxford Pharmagenesis facilitated this process for us, and they were certainly indispensable. And then this was also supported by all 4 cochlear implant manufacturers, Advanced Bionics, Cochlear, MED-EL, and Oticon. So let's see if Okay, so this, just to give you some sense, the Delphi Consensus Group was a group of both surgeons and audiologists and other hearing professionals from around the globe. And this shows from all the different countries that were really represented here. And the KPAC, as Barbara referred to, is a group of consumer and professional advocates. And you can see the various organizations that were represented. So really quite a broad representation from across the globe. The KPAC group was involved in reviewing and providing feedback during the generating of the consensus statements and the voting process. And our hope is that the KPAC will help disseminate the information that you're going to hear today. So as many of you may know, hearing loss is exceedingly common. In adults, up to over 450 million people are affected today. Children are a smaller proportion of this. And it's been estimated that the incidence of hearing loss will at least double by the year 2050. So this is a problem that is really rapidly growing. One of the interesting findings in the last number of years is that hearing loss has been associated rather well with the onset of dementia, and it's actually been recognized as the single most modifiable risk factor for dementia. And so this is certainly information that makes us all a little nervous, and we all recognize how important it would be for an intervention that might slow our cognitive decline as we age. For those who don't know, cochlear implants have been around for over 30 years. They're widely recognized as the standard of care really for children with severe to profound hearing loss, and more than 50% of children with this significant level of hearing loss ultimately go on to cochlear implants. And I think most people would recognize this as sort of common therapy. For adults, though, it's a little different. Adults oftentimes spend many years in hearing aids, and they think of cochlear implants more as a sort of a last resort rather than sort of the typical standard that you would move to when hearing aids aren't sufficient. Looked at another way, on the left side of the screen, what you see is this bubble, which is the roughly 450 million adults out there with significant hearing loss. Of those, maybe 53 million have severe to profound hearing loss, and they would then potentially be cochlear implant candidates. But interestingly, if you look across the various databases across the world, only about 5% of patients that are cochlear implant candidates today actually receive the device. So it's really very, very low penetration. What we do know about cochlear implants is that they work. They work exceedingly well. The surgery for these is very safe. Takes no more than about an hour to an hour and a half to do. In fact, I did 2 this morning before this talk. And cochlear implants rarely result in big complications. They certainly improve speech understanding in both quiet and in background noise, which, as you would all guess, can result in educational and employment opportunities and improvements in quality of life. And then finally, they're certainly very cost effective. If I had to summarize anything about the entire day or entire talk today, it's really this slide. Cochlear implants are well underpenetrated into the candidate population, but they work really well and they're very safe. So I think you'll hear us say that over and over as we go through the presentation. So I'm going to move forward. So our process in getting together and doing this consensus statement was really to try and gather the world's literature that's out there and bring it together as a body of evidence, and then bring the world's experts together and have them provide opinions on this body of information to ultimately try and bring this forward as the basis of what we understand about cochlear implants. And so this sort of shows a schematic of what that process might look like. And then ultimately we would take this consensus information and use it to try and better deliver cochlear implants to the candidate population and try and improve that penetration that we talked about. So I'm now going to talk sort of about the systematic review process and consensus statement. We chose to only go after unilateral cochlear implantation in people who were affected in both ears. There are other indications for cochlear implants that are out there, but this is the one that we focused on. And below, as you see the various names, those are the people who made up the Delphi consensus group. So you might ask, why Delphi? What's a Delphi? Delphi is really an established consensus-based technique that allows groups to get together and express opinions to ultimately come to a consensus. So the Delphi process is sort of a back and forth iterative process that allows people to come to some understanding as to what we unify around and believe. It requires several rounds of questions and then answers, and then modifying the various statements until we get to an endpoint. I'll pass on this. And so this gives some background. We started this process back in July of 2018, so it takes a long time to get to the end game. These are the various domains that we sought to look at. You can see level of awareness was a main one, best practices for the diagnosis of hearing loss, best practices for surgery, rehabilitation, clinical effectiveness, factors that impact performance with cochlear implants, and cost. What you will notice is that there wasn't good, strong literature behind rehabilitation that was reviewed in this particular document. So you'll see the various domains that we covered, and then we'll talk a bit about the statements that came from this. So interestingly, in those various domains, there were nearly 7,000 research papers that were out there. And so to whittle down 7,000 research papers to something that's manageable, you can see we had a very detailed Prisma diagram, which shows how each of those were excluded. This was most of the world's literature on cochlear implants, was the 6,500 or near 7,000 papers. And then we got down to 74, which really were relatively good quality studies and also addressed the issues that we wanted to address. And so this shows a bit about what the Delphi voting process looked like. I'm not going to go into any detail except to say that, if a statement was made and then it was voted upon and we felt that, and the vote, less than 75% of the Delphi group thought that it was appropriate, then we would modify the statement and then have it re-voted upon. So in the end, we got to agreement on 20 statements. And so you'll see those statements, and I feel really good about saying that these statements are really a good summary of the world's literature in these areas. So here's those 7 categories that we talked about. And so I'm going to just go through each of the statements so you get a sense for what's there. Some of them might not be relevant to some of you who are watching, and then some may be. So excuse me if some of them don't seem relevant. So as you would guess, because awareness is so low, the statement that came out around awareness is that awareness of cochlear implants among primary and hearing health providers is inadequate, and leading to under-identification of eligible candidates. And so that's probably no surprise. It's interesting that there's only one paper out there on cochlear implant awareness today. So it's a pretty under-touched topic. In terms of best practices for making the diagnosis, we said that detection of hearing loss in adults is, of course, very important, as you all would guess. And pure tone audiometry screening methods are considered the most effective. And the addition of a questionnaire or an interview to the screening can improve the detection of hearing loss. So I think this is super, super important. And many of you know that outside of hearing healthcare providers, identification of hearing loss is pretty poor. And then 3, and I don't know that this is relevant to everyone, but it's preferred that aided speech recognition tests for cochlear implant candidacy in adults include monosyllable words and sentences conducted in both quiet and in noise. For those of you who have undergone a cochlear implant candidacy assessment, that's the sort of testing material that most of you will see. And it should be done with your hearing aids in place. This was a very important statement, and the literature really strongly supports this, is that age alone is not a limiting factor for cochlear implant candidacy. So irrespective of what your age is, you still can be a cochlear implant candidate, and people of all ages have shown benefits. So that in and of itself, just the number, doesn't necessarily disqualify you from being a cochlear implant candidate. In terms of best practices for surgery, this might seem very specific. Both curved and straight electrodes are clinically effective for cochlear implantation with a low rate of complications. What this really distills down to is that all of the cochlear implant devices that are out there are clinically effective. They all improve hearing substantially, and the complications rate from cochlear implantation, again, as I said earlier, are really exceedingly low. There's sort of a new move afoot out there to try and preserve people's residual hearing for obvious reasons. And so the sixth is when possible, hearing preservation surgery can be beneficial in individuals with substantial residual hearing. The fourth domain is about the effectiveness of these devices. The first statement is that cochlear implants significantly improve speech recognition in both quiet as well as moderate noise. So, as I said before, these cochlear implants really work at improving speech understanding for those with bilateral severe and profound or sloping hearing loss. And also importantly is that these benefits that people see are stable over time. So most of the literature supports that hearing the effectiveness of the cochlear implant doesn't get worse over time. And both words and sentence tests should be used to evaluate, as we talked about before, after cochlear implantation as well as from before. So the next area is post-implant outcomes. And the group found that when appropriate, individuals should use their hearing aids with their cochlear implants in order to achieve bilateral benefits and the best possible speech outcomes. This is always an important thing that patients wonder about, is whether they should continue to use their hearing aids. And the literature really is quite good on this topic and really has shown that a cochlear implant together with hearing aids is certainly better than a cochlear implant alone. And in fact, these things can be synergistic, meaning that they work together. And while there certainly are more research that's needed in this area, we strongly encourage that in all of our patients with substantial hearing. Another sort of a misconception that's out there is long durations of hearing loss are contraindications, and actually the literature doesn't support that. So the literature supports that long durations of unaided hearing loss do not rule out potential benefit for cochlear implants. And so individuals who've received an implant in an ear that was previously unaided for more than 15 years have still been shown to gain a lot of benefit. That's something that we commonly hear in the clinic, is that, you know, their ear has been not useful for a long time, and the literature supports actually still getting implants when they haven't worn a hearing aid for many, many years. And then adults should receive programming sessions as needed to optimize their outcomes. So in the early parts after implantation, of course, this is relatively frequent, and as time goes on, it's less frequent, but it's still important to continue to troubleshoot and to also make sure that their maps stay stable over time. So this is a really interesting area that's really become much more commonly researched in the last decade, and that's the relationship between hearing loss and depression, cognition, and dementia. In fact, there's a number of statements that popped up because of the increasing literature around this space. So one statement was that adults with hearing loss can be substantially affected by social isolation, loneliness, and depression. And evidence does suggest that the treatment with cochlear implants can lead to improvements in these aspects of well-being and mental health. So that's something that is really starting to emerge in literature, is that implants can make a big difference in this area. And then also there's an association between age-related hearing loss and cognitive and memory impairment, as we talked about before, the issues with dementia and potentially Alzheimer's. Certainly there's further research that's required to confirm the nature of the cognitive impairment and its reversibility, but there's literature now starting to lean in the direction to suggest that the use of cochlear implants may improve cognition in older individuals with bilateral hearing loss, meaning that as we all get older, we all have some degree of cognitive decline, and the literature is starting to suggest that maybe the slope of that cognitive decline can be lessened if you have substantial hearing loss and you're in need of a cochlear implant. Importantly, hearing loss is not necessarily a symptom of dementia. However, treatment of hearing loss may reduce this risk, and I think that's what we're trying to imply. And then the last area is our cost implications. And basically, unilateral implants in adults are considered very cost effective when compared to no implant or no intervention at all, and is associated with increased employment and income. And so these devices certainly have life-changing implications. So next steps, well, this is part of the next steps is what we're doing today. We're talking about it and starting to try and get the word out there. This is sort of the beginning. Our next point would be to go on to develop clinical practice guidelines. A clinical practice guideline is a more formalized way of summarizing this data and using it to disseminate to sort of the world at large. And of course, the ultimate goal is to try and improve hearing and quality of life in the most people that we possibly can through cochlear implantation, if that's what's necessary for an individual. So as Barbara mentioned, this paper has now been published in JAMA Otolaryngology, and it's getting a nice number of reads. And it's been out there and of course tweeted and is out there on Instagram and another number of other areas. So and now sort of the real work for us begins in trying to disseminate this information out beyond just a paper that's in the medical literature, but trying to get it out there to professionals in the community, ultimately go on to develop these practice guidelines and maybe even develop policy around this work. And so it also, it takes a village to get this information out there. It's certainly not one person that can do it. And you can see here, we've tried to outline the various groups of people that are stakeholders in this effort. I'm obviously a clinician, but those from industry as well as payers, the KPAC, which have already been very, very successful at helping us, organizations such as your own, as well as individual recipients. Really, this work falls on all of us to try and get the word out. And so that's the information that I have today. I want to thank you all for allowing me to talk. And next up will be Dr. Renee Gifford, and she'll speak some more. And then afterwards, we'll have time for some questions. So Renee, it's up to you.
Thank you, Dr. Buckman. Hi, everyone, and thank you so much to HLAA for inviting me to speak about this. It's a topic about which I'm very passionate, and I'm really excited that from a global perspective, we can start to really work together as a team to really spread the word about cochlear implantation with respect to safety, efficacy, cost effectiveness, and everything, because the utilization, as Dr. Buckman has mentioned, and as many of you likely already know, is extremely low. Okay. I'm looking for, I thought I had remote control. There we go. Okay. So as Dr. Buckman mentioned that there is this, before this consensus paper, there's really been no international guidelines on cochlear implant candidacy in adults. And really, this is really not the only problem. There's problems because candidacy varies dramatically across countries, across regions. We know that all of the manufacturers of cochlear implants have different criteria. There are different criteria even amongst insurance providers. So we know that, for example, Medicare has slightly different criteria as compared to standard commercial insurance. So this leads to some confusion, not only amongst the public, but amongst us as professionals. And so this has been a key contributor to the poor utilization of this technology. The barriers to this technology have been, of course, public awareness, as we've mentioned. I always like to think of this as if I walked into a Target or a Walmart or a Kroger and just walked up to a random person and asked them, tell me what you know about cochlear implants. If they even knew about cochlear implants, which I think is a big if. I think that most people would say this is something that children who are born with hearing loss can use, or it's something that people who have no hearing whatsoever could potentially use. And as we know, this really is just not the case. Cochlear implant criteria have evolved dramatically since this was first FDA approved in 1985. The other, of course, is just knowledge about what the criteria actually are. And of course, adding to the confusion is there really are different criteria across the manufacturers and across different insurance companies and the global regions. But the referring providers often are just not up to date on what a candidate actually looks like. What does the auditory profile look like? So if you think about, the vast majority of people are not seeing audiologists and otolaryngologists on a regular basis. So people are seeing their primary care providers, they're seeing maybe nurse practitioners, other specialists. And these specialists rarely will even address an issue of how one's hearing is. And if they do happen to inquire about their hearing, it's very rare that they're going to refer to a specialist to consider cochlear implant or to at least consider additional more powerful hearing aids. And of course, that leads to the fact that there's really this lack of defined care pathway. How do people get in to see audiologists and otolaryngologists? Many patients will when they finally come in to see me, will say, I had no idea that I was able to actually self-refer myself. They thought that they would have to get, their primary care provider or some specialist would have to make a referral to our cochlear implant program, which that is just not the case. So you might be wondering, well, why is this a problem? Well, the problem is that there's a global burden of hearing loss, as Dr. Buckman mentioned. And so there are many estimates out there, but there's at least 53 million people around the globe that have severe to profound hearing loss. And so just to put that into perspective, that's roughly equivalent to the population of the entire country of South Korea, or the entire country of Colombia, or the entire country of Kenya. To put it into the perspective of the US, that is equivalent to the populations of California, Pennsylvania, and Washington, DC combined. So we're talking, there are a lot of people around the world who have the severe to profound hearing loss. And we also know there are very few of those individuals who have actually pursued cochlear implantation. So what the problem is, when hearing loss is untreated or undertreated, in the case of someone who really meets candidacy and is using hearing aids that aren't providing, adequate benefit for communication, this really can lead to communication problems, quality of life issues, well-being, ultimately isolate an individual from everyone else. And this is really problematic and can lead to a lot of the things that Dr. Buckman had mentioned, particularly possibly lead to increased risk of incident dementia. And of course, we all know how this works today because we've all sort of experienced how much we really depend on visual cues. So even some of my my family members of patients, and myself included, we're struggling because we have the mask that we're wearing in most of our everyday communication, and it's really shown how put away from each other we are, and how adding hearing loss on top of that can really significantly impact our communication abilities. So as I mentioned, there are really dramatically different criteria for cochlear implantation. And thankfully in the US, there's really broad criteria today in 2020. So we have actually sort of three categories of candidacy that one can qualify for a cochlear implant. So first of all, there's conventional cochlear implants. And this is what we talk about that's been approved really since 1985 in adults. So these are individuals now with moderate sloping to profound sensorineural hearing loss, typically are seeing speech recognition abilities up to 60% correct with appropriately fitted hearing aids. So it's not just profound loss, and it's not just severe to profound. We actually are talking moderate sloping to profound, and this is labeled with Cochlear as well as with Medicare. Then there's the category of the hybrid or the EAS. So EAS standing for electric and acoustic stimulation. So these are individuals, as Dr. Buckman mentioned, who might have reasonably good low frequency hearing, and we really want to preserve what remaining residual hearing those patients have. But they might have this precipitously sloping high frequency hearing loss that really, these hearing losses, I can say as an audiologist, are the most difficult to fit with hearing aids. Because in the lower frequency region, patients really just don't need much amplification, if at all. And in the higher frequency region, they need maximal amplification. And the problem, of course, is that the underlying physiology, what's happening at the level of the cochlea, is there's such sufficient damage when you get to that degree of hearing loss that even if we could get the most expensive hearing aid in the world with the very best receiver, it's not going to be enough to transmit those very important speech frequencies so that the patient can use those for effective communication. And then finally, there's now a single-sided deafness criterion that we have had in approval for just over a year. Now, I do want to point out that Medicare does not currently support the single-sided deafness criterion, but we do actually now have much greater acceptance with respect to insurance authorization for getting cochlear implantation covered for individuals who have normal or near normal hearing in one of their ears. And in fact, even if we think about these three criteria, so these buckets of criteria for cochlear implantation, even if we look beyond these criteria, so looking at people who exceed these current criteria, so maybe someone who's not quite a hybrid candidate, but they're better than a conventional cochlear implant candidate, we know there's increasingly larger studies and populations of literature showing that patients that are exceeding these criteria, or what we might call off-label cochlear implant candidates, are showing tremendous benefit from cochlear implantation. And in fact, I'm going to show you just a few slides with new data. So shown here are some of our new data from a recent study that's currently under review. And what we wanted to look at is, we really just wanted to provide an update to the literature on how adults who are exceeding current candidacy indications, how they're performing with cochlear implants. So what we did was we looked at our entire adult cochlear implant database at Vanderbilt, and we identified 105 adults who had exceeded what a previous trial had set as its limits for cochlear implantation. So back in 2007, there was this large study, and they had set 30% or lower as being the indications for monosyllabic word recognition in the ear to be implanted. So in fact, that's what we did. We looked at, if you can see over here on the left-hand side, this is CNC, or monosyllabic word recognition in percent correct. And then we have the scores for the preoperative time point, as well as 12 months following activation. And this is for 105 individuals. And you can see that everybody preoperatively did better than 30% correct. And in fact, the mean was 40% correct at the group level. And what you can see is that even this group of people who are really non-traditional candidates, but may not have met the candidacy for EAS or hybrid, are all showing varying degrees of benefit from cochlear implantation, such that the mean now is 64% correct. Looking over here on the right side, these are the same data, same people, but instead of looking at the implanted ear, we're looking at the bilaterally aided condition. So this would be combining a hearing aid plus a cochlear implant on the other side, or in the small number of cases in this particular population, 2 cochlear implants. And so what you can see is that, again, even though these individuals were performing, in some cases, near 80% correct in the best aided condition preoperatively, we're seeing benefit of cochlear implantation. And this is just on one metric, monosyllabic word recognition, without visual cues. So imagine now you add contextual cues, because we speak in sentences with lexical meaning and linguistic relevancy, and you add visual cues, of course, when we're not wearing our masks in public, and you can really see how communication effectiveness is really improved by cochlear implantation. And you might be wondering, of course, well, what did their audiograms look like? So these were the 105 audiograms for those individuals. And you can see it's a really dramatic, broad distribution, ranging from some individuals who had normal hearing in the low frequencies, and then these precipitously sloping drop, and even some people who had what we would call a profound sensorineural hearing loss in both ears, but who were very good users with their hearing aids. So kind of everyone in between. And so we know that cochlear implants really are useful and effective even beyond what the limits of this consensus paper is showing. And so I want to summarize that we mentioned earlier that cochlear implants are highly effective and they're highly underutilized. So we know that really within the walls of progressive academic medical centers like Washington University or Vanderbilt University Medical Center and a number of other centers, these consensus statements are in practice already. So we're already, applying cochlear implants to anyone who would come through who meets the criteria or who is struggling significantly with communication. But the problem is this is not happening globally, and it's not even happening nationally within our country. So we really want to, we're in a position now where we're not having to document that cochlear implants are safe and effective. We know that cochlear implants are safe. We know they're highly effective. They work, and they work very well. We know that they're cost effective. And we know that they can bring communication abilities and quality of life and improvement in various aspects of one's life beyond that hearing aids can offer for the right individuals. So just having this publication out there is really simply not enough. And so as Dr. Buckman mentioned earlier, part of our next steps is one of these, the HLLA webinar we're on right now. But really, it's not just us as clinicians and clinician scientists. This is going to be work from all of us. We have to get the awareness out there about cochlear implants. We have to get the awareness to the public, to our primary care providers, to audiologists. You'd be surprised how many audiologists who don't work with cochlear implants aren't aware that someone who has moderate sloping to profound hearing loss is actually a candidate. And there's also ear, nose, and throat surgeons who might not be working in cochlear implants. They might be just general otolaryngology practice, and they're not necessarily aware of current indications for cochlear implants. Patient advocacy groups such as HLLA, we've got to work as a team because we all are working toward the same goal and the same mission to bring this technology to more people who could benefit. Of course, we also have to do a little bit more work on our part. We're clinician scientists, and we love to quantify outcomes with respect to speech recognition and quiet, speech recognition and noise. And only recently have we started to qualify the improvement in one's quality of life. And insurance companies are increasingly more interested in how quality of life and well-being is being improved by a specific intervention. And so we're collecting those data. And then, of course, it's very important for us to just start screening hearing for more and more people. We know that we expect the prevalence of hearing loss to double by 2050. So getting the word out there and explaining to individuals that cochlear implants aren't the last resort, as they're often described. They're one step in the continuum of that hearing healthcare trajectory, starting with potentially over-the-counter hearing aids, moving to more conventional or prescriptive-based hearing aids, then moving on to cochlear implants. It should be discussed from the beginning when someone first has a hearing loss, and not brought at the very last minute that, oh, there's nothing else I can do for you. So we do have a lot of work ahead of us, and we have to be committed to outreach. And so this is not just having webinars, but if you're active on Twitter, getting out there and tweeting, retweeting, presenting the information on social media, or just speaking to your neighbors or anyone who you can speak to about this technology. So I want to thank you for your time, and I think at this point I'm turning it over to, is it Barbara?
Hi, no, it'll be me.
Sorry about that.
That's all right. We're just ready for our question and answers portion right now. And I guess I just need to ask if my guests can actually see the question and answers on their screens, or do you need me to read them out to you?
So I actually even started answering some of the questions. I was typing answers back to some of the people as we were going through, because some of the questions were longer. But I can read a few of these if you want.
Okay, that'd be great. Thank you.
And maybe either Renee or I will jump in and decide who can best answer. The first one is a former CI Center lead. This is from Brad Agraya. As a former CI Center lead in the VA and in the private sector, it's my observation that poor penetration is largely due to the persistence of the concept that CI work should be a subspecialty of audiology. In addition, very few recipients have spoken, that I have spoken to, report anything close to standardized or optimized evaluation and follow-up across centers. Renee, you want to take that?
Sure. Brad, you're absolutely right. And that's part of the problem. Some centers will be testing with sentences in quiet, some test sentences at +5, some will only look at the bilaterally aided condition. Some look at individual ears. And so we really have to move towards much more standardized assessment for individuals. And so we are moving as a field to looking at individual ear, sort of ear specificity, just like, you know, ophthalmologists and optometrists wouldn't give you a prescription that's just for your two eyes together. You want to correct each ear individually to get the best binocular vision. Same with hearing. And so at our center, and I know at WashU, we look at each ear individually, as well as characterizing the bilaterally aided condition. And by bilaterally or best aided condition, we absolutely do verify ear canal SPL by looking at probe microphone measurements, you know, using a AudioScan VeriFit or whatever system that we have. And you're absolutely right. We've got to do a much better job. And we're actually, as a field, moving more toward a monosyllabic word recognition criterion. It's something that's more really, even in general audiology and general otolaryngology, word recognition just sort of makes sense because we do that with, you know, just standard diagnostic procedures. And in taking out all of like the sentences and noise and all of the different things, just putting it at monosyllabic words would really help streamline things. Would you agree with that, Craig?
Yeah, you know, in fact, just to jump on like go one step further, I've always sort of felt like there's some magical leap that has to happen between a patient who comes in with a hearing loss and has a diagnostic audiogram, and then somehow from there to a cochlear implant evaluation, there's some magical step that happens in between. And honestly, I think that we need sort of something that simplifies that process so that when a patient has an audiogram, it's absolutely crystal clear. Or as clear as it can be, whether or not someone should undergo more formal testing. I know that some have suggested that you know, a pure tone average of worse than 60 decibels or a word recognition score of worse than 60% might be someone that you should think strongly about it. And Terry Zwollen, you know, as you know, did some work on this topic and sort of found that a large number of patients that met that criteria actually were ultimately cochlear implant candidates. And so I think there's, and I think, Brad, you bring it up, is that there's a serious need for demystifying this whole process around who is or isn't an implant candidate. And I think, frankly, on the post-implant side, I think the post-care needs to be simplified greatly. And I can certainly envision the day where mapping, I don't want to take anything away from the CI audiologist, but I certainly think that garden variety mapping that might be very straightforward certainly might be something that can be accomplished by patients at home looking at their own, you know, their own computers. So
I agree entirely with that.
So
and just to follow up on the second question from Brad, when he was, I kind of answered it a little bit with respect to best aided condition. We do look at frequency lowering, optimal acoustic coupling with ear molds and so forth. And I do want to point out that there's still really no concrete evidence that if you have someone who meets criteria without frequency lowering technology, there are no papers that have shown that once you add that in, that it actually would elevate someone's performance to basically, you know, to where they wouldn't meet candidacy anymore. I have a paper from many years ago now that showed the same thing, but we absolutely test it because it's sort of like we want to do the very best we can to give them every piece of audibility they possibly can have. And then if they're not meeting candidacy, it's time to consider an implant.
So a question from Richard Pocker says, does the paper discuss the use of hearing aid during rehabilitation? The answer effectively is yes. You know, we looked at papers that looked at sort of bimodal versus using the CI alone. And that was one of our findings, is that using a contralateral hearing aid with their cochlear implants certainly improved performance. And there's a number of papers that really support this rather strongly. So I don't know, Renee, do you have anything to add to that?
Yeah, I mean, certainly we know that any two-eared hearing condition is going to give us better hearing than just one ear. But there are no specific studies that have actually been able to document that if you use both the hearing aid and the cochlear implant during your all rehab, or just isolate the implanted ear during rehab, that one is better than the other. So there haven't been any sort of randomized control trials. although there's plenty of anecdotal evidence out there with, I'm sort of strengthening the pathway of using the cochlear implant alone during rehab. But again, I sort of tell my patients, I want them to maximize their hearing from day one. And if they want to spend some time each day with just the implant, that's fine. But let's get you hearing out of both ears and integrating those two signals as soon as possible.
Okay, another question, and I'm sorry, I won't pronounce your name because I'm sure that I would butcher it, but the question was, did this publication extend to sub-Saharan Africa? The answer is that this publication extended to the English literature. And so all of the English literature that was out there was reviewed. And so if there was a publication that was not within the English literature, we didn't capture it, but literally everything else was looked at. Remember, there are some determinations made along the way as to the quality of the various articles that were out there, and whether they sort of crossed the bar to be able to be included. So that's really that. There was a question from an anonymous attendee. What do you think about implants that do not include a telecoil? I was surprised to hear that is now an option. Dr. Gifford, do you want to touch that?
Sure. Yeah, so I think that for people who know how much you can get from a telecoil, specifically within induction loop systems, it is, I have concerns about that. For people who might not have access to induction loop or not even aware of it, they don't really know what they're missing, because all they seem to care about these days is the phone and streaming via Bluetooth. But I do think I think it's a bit of a mistake to remove the telecoil completely, particularly in some regions. There's some regions of the country where there's much greater looping. Like for example, in like Wisconsin, I know there's a lot of looping there. And then there are some regions such as Europe is heavily looped. And I would really hate for patients getting cochlear implants to not be able to access that.
Great. Question from Laura Ryan. What circumstances would make a deaf person a poor candidate for implantation? Well, if someone has had, congenital hearing loss and they've been profoundly deaf for many, many years and don't use a oral communication mode, I think this would certainly create a difficult situation. Oftentimes we've seen patients that have many, many years of profound deafness and are primarily using sign language that when they have received a cochlear implant, they generally don't like the experience that it gives them. There are obviously some basic things like you have to have a cochlear nerve present. So if you've had a tumor and had that tumor removal and it's removed your cochlear nerve, then you might not be a good candidate. If you've had many, many years of ossification of your cochlea following meningitis as a baby, then you might not be the best candidate. But people who have had less than profound hearing loss or progressive over time, even if it's been for many, many, many years, still can be really excellent cochlear implant candidates. Anything to add to that, Renee?
I don't. No, that's perfect.
Great. Question from Susie Harris. Is it true that adult criteria for cochlear implants has not changed significantly in the US since 1985? It seems to me there was a big change maybe 5 years ago. Renee, you want to cover that?
Yeah, so I don't think that I said that. I think I might have misled you. What I meant is that many people who are referring to us for cochlear implants aren't necessarily aware that criteria have evolved dramatically over time. So we know that in 1985, it was profound bilateral sensorineural hearing loss. And then in the late 90s, it moved to severe to profound. And then in 2005, it moved to moderate to profound. So with respect to conventional implants, there really hasn't been much of a change since that time. But we've had the addition of EAS and hybrid devices, and now the addition of SSD indications. And so that's where things have been evolving. But a lot of people, if they're not up on the literature or aren't working in this field, they might think, oh, implants are only for people who have, bilateral profound loss. And so this patient that I'm working with right now isn't really a candidate. So that's what I had meant. I apologize if I misled you on that.
Yeah, and in fact, the vast majority of patients, and I think Renee really referred to this, the vast majority of patients that we're seeing today are not profound, from the low tones all the way to the high tones. In fact, most people have a sloping hearing loss, and many have actually a lot of low frequency residual hearing. as well. One of the things that is currently ongoing is a group of us, including Terry Zwollen and myself and Jill First and some others in a variety of centers, including Vanderbilt, have been working to expand the criteria for CMS. CMS, as you all know, is the Center for Medicare and Medicaid Services. And so we just finished a research paper that ultimately shows that we probably should reach toward expanding our criteria even among the Medicare population. That doesn't, of course, include the asymmetric that Renee referred to, or the single-sided hearing loss, or some of those others, EAS. But I think all of these, there's works on all of these fronts, sort of moving criteria forward. Question from Mustafa Ahmed. I may have missed this. How are payers reimbursing off-label use? Renee, do you want that one, or you want me to take it? Go ahead.
Sure, I'll start, and then I think maybe you could finish off on that. The key is that in the US, I can only speak to the US market, the FDA has actually has a guidance document on the off-label use of drugs, biologics, and biomedical devices. And so, it's encouraged that if the clinician is well-informed and has scientific evidence of the efficacy of an intervention for that particular patient and documents the use of that particular intervention, that they can absolutely recommend off-label use. So what we would do, at least the way I work it, is that if, let's say, a patient scores above 60% correct on sentences, which is the criterion today for conventional implants, but they're showing dramatic, they have a very demanding job. So like I had a trial attorney one time who was, exceeding the criteria, and I just make a very strong case in my letter of medical necessity to get prior authorization. And I haven't had difficulty in many cases. The cases I've had the most difficulty have been the SSD, or the cases where you have normal hearing in one ear. Although since the indication came about last year, that's been less of an issue as well. Dr. Buckman, you want to add to that?
I think that's been our experiences as well. I mean, for patients who fall outside of sort of conventional criteria, as you were referring to, oftentimes it requires a peer-to-peer discussion with payers that will do that kind of work. We're often pretty careful about doing it in the Medicare population because there's not really a as clear of an opportunity to do that. But certainly, in the end, these decisions are related to clinicians and patients sitting down and making individualized, decisions given their particular situation. And so oftentimes we do work our way through these, and it might take longer for some patients than others, but oftentimes we're successful. So John Elliott writes, can the regenerative techniques that are currently being FDA tested be used after cochlear implants are placed? John, I think that's a really interesting question, and the answer is we don't know. I think we all believe that regenerative biology ultimately will play a role in restoration of hearing, but it's pretty far off. There are people that are working at this pretty hard, but today we're still left with talking to patients and making decisions about today. One of the things that we all worry about, and I think you're sort of referring to this in a way, is if you put a cochlear implant electrode inside the cochlea, will that somehow destroy some substrate that would ultimately be used for regenerative technique? And the answer is we don't know. And so I think only time is going to tell how these work. The other part that goes with that is our regenerative techniques going to be connected to cochlear implants, meaning are there going to be electrodes that elute different sorts of substances that ultimately help in the regenerative process? And my guess is that'll happen in time as well. So only time will tell, but that's a really interesting question. Question from Ruth Warwick to Dr. Gifford. Are there country differences in criteria for CI candidacy, and what are these?
Yeah, there's lots of country differences. So I don't know all of them, but for example, in the UK, they use what we call the BKB sentences. And for adults, they require patients to score less than 30% correct with hearing aids. They rarely will implant bilateral implants for adults in the UK. whereas compared to, the United States, it's based on 60% sentences, and standard of care is bilateral for most patients. And then, for example, in Germany and in Spain, they look at monosyllabic word recognition up to 30%. And then Australia has its own set. And so there's all these, every country and its own regulatory agency has a specific set of criteria. So you can see how it gets very confusing looking at this from a global perspective. And so that's one of the goals of this document, and ultimately moving forward with standards of care and practice guidelines, is to try to really bring this standardization so that we can get more people in the pipeline.
Yeah, I completely agree. And it's tricky, right? Because if you think about the tonal languages, they're quite a bit different than the type of language that, spoken English or other languages. And so much of the information that you saw in our various statements will have to be distilled down for each of the countries to use. And so I think it's unlikely that we'll have a single clinical practice guideline. Rather, we'll probably have practice guidelines that pop up in many different countries based on their cultural differences, language differences, health delivery systems, et cetera, et cetera. So it's a very great question. Neil Steiger asked a question. I think we're going to have to stop here a second, but what are the most significant factors deciding whether cochlear implant surgery will maintain residual hearing? And I wrote back to him to say the degree of preoperative hearing and electrode insertion depth, and we're still learning about the biologic responses. And then he came back and asked, please explain greater depth. And what that means is that electrodes that go really deep into the cochlea have a greater risk of trauma to the internal cochlear structures. And so, as you would guess, really short electrodes only go into the cochlea a very short distance. And so their ability to preserve residual hearing actually is higher, but they might be too short. And so one of the things that we're struggling with in the field is trying to optimize cochlear implant electrode insertion depth, or the number of millimeters that's pushed into the cochlea, while still trying not to destroy any of the intracochlear architecture. And so that's certainly an area of research that I know many centers are working on. So I don't know, do we have time for another question or two? I don't know, Barbara, or where do you think we are here?
Yes, you have time for one more question. Go ahead.
Okay. Anonymous attendee, is imaging during surgery to ensure proper electrode placement being considered as a requirement for CI surgery? So good question. Intraoperative imaging, which can either be done in the form of a plain film, which is just like a plain flat x-ray. It can be done as a CAT scan, or it even can be done as something called fluoro. All three of those are sort of commonly done out there, but I would say that it's not standard. So there are many centers that do not do intraoperative imaging. And so this is something that's sort of been evolving over many years. It's very hard to talk to surgeons about requirements. In one of the recent trials that we did, we learned that some of the electrodes were more predisposed to folding over as they went inside the cochlea. And so surgeons over time began to recognize that this was a really important part of it. So I would say, sort of to answer your question, in large part, it's not an absolute requirement, but it's becoming more and more common over time. And CT scans are even better resolution and give prettier pictures of where electrodes are ultimately ending up inside the cochlea. And this might be relevant to performance in future. So I think should we wrap it up at this point?
Yeah, I think this would probably could be a good place to stop. We have about 43 questions on the call today, so I don't think we will be able to cover all these questions today. So our panel has graciously offered to address some of these questions post the webinar, and so we will try to get a document on the website along with the recording at a future time. So I just need to thank Dr. Buchman and Dr. Gufford for their time today, and I thank Deanna Baker for her wonderful CART services today. As I mentioned, the webinar will be posted to the website at hearingloss.org, along with the question and answer document that will be addressed later. Barbara, I'll go ahead and pass it on to you. Go ahead.
I just want to thank our presenters today. This has been really valuable time. And HLAA is going to do everything it can to make sure that these consensus statements get broad distribution. And I encourage all of you in our HLA chapters to do the same, and as individual advocates. So thank you, Drs. Buckman and Gifford, and everyone who attended today. We really appreciate it.
Great. Thanks for having us.
Bye.
Thank you.
Stay safe and be well. See you next time. Bye-bye.